everyone. And thank you for joining us today for the International Society of Exercise Oncology webinar series. The ISEO webinar is designed to bring together a global audience of researchers, clinicians, individuals who live with cancer, and healthcare decision makers, with the overarching goal to foster exchange between us, enhance communication, and build the capacity of the exercise oncology research community. Before we get started, we have a few housekeeping things that I would like to share. I would like to ask all of you to mute yourself during the webinar. And at the end of the webinar, we have reserved some time to answer your questions. You can put your questions in the chat during the presentation. And at the end, we can ask you to speak up, or otherwise I can share your question on behalf of you during the Q&A session. Due to time constraints, we may not be able to get all of your questions, but we will do our best to address them today or afterwards. Well, please note that the webinar is being recorded and will be available on the ISEO webpage in the next few weeks. Well, that's it for the housekeeping stuff. Now I would like to introduce myself as the moderator for today's session. I'm Anouk Hiens. I'm an assistant professor at the University Medical Center Utrecht in the Netherlands. And as an ISEO webinar program committee member, I've been asked to moderate today's session. But now let's get to the fun part. I would like to introduce Anna. She is today's speaker, and we are very lucky to have her speaking to us today. So Professor Dr. Anna May is a professor in clinical epidemiology of cancer survivorship, and she's a research director of the Julius Center at the University Medical Center Utrecht in the Netherlands. She is also a group leader of the Lifestyle and Functioning in Cancer Survivorship team at the Netherlands Cancer Institute in Amsterdam. And starting during her PhD and ever after, she is investigating the effects of lifestyle on treatment-related side effects and prognosis, as well as the underlying mechanisms, with a special emphasis on physical activity and exercise. She has been involved in exercise oncology research for more than 20 years and has performed several multi-center randomized controlled trials showing positive exercise effects on treatment-related side effects in patients with, amongst others, breast, colon, and esophageal cancer. She also serves at lifestyle and cancer-related guideline panels like the ESCO and ACSM guideline panels. And lastly, she's also committed to implement the positive results regarding lifestyle in clinical practice, so that as many patients as possible can benefit. Today, Anna will speak about the beneficial effects of exercise in patients with metastatic breast cancer. And in this talk, she will present the current evidence from randomized controlled trials on the effects of exercise for patients with metastatic disease. And she will highlight the results of the preferable effect study and report on the effects of the 9-month exercise intervention on physical fitness, patient-reported outcomes, as well as the findings on cost effectiveness. And finally, she will also share a patient perspective. And with that, I would like to turn the floor to Anna and give the floor to her.
Yes, thank you, Anouk. Thank you for this extensive introduction and thank you for inviting me. Before I will start my presentation, yes, I first wanted to spend a few words on the International Society of Exercise Oncology. Since this is an ISEO webinar, I think it's nice to give you an update on where we are with the society. And I'm happy to announce that this month the bylaws were approved by the board of directors, and also our website is live. The website is still work in progress, so please, take a look, but there will be some changes coming in the coming weeks. Furthermore, we also now published the mission statement of the ISEO on the website. And this reads as follows. ISEO is a new organization formed to increase awareness of the critical role that exercise plays in cancer prevention, treatment, and survivorship. ISEO's highest priority is changing the standard of care in oncology to include exercise medicine throughout the journey for patients with cancer, from diagnosis through treatment, survivorship, and palliation. And two more practical issues. I'm also happy to announce that you now can join the ISEO officially and become a member. In the first years, we also have the possibility to become a founding member. And on the website, you can find all the details on membership. We are still a bit in the process of adapting the form to apply for the membership. So I would advise you to do that not today, but perhaps next week. And lastly, I hope that I can meet you all at the inaugural conference, which will be organized in Heidelberg next year in July. So with that, I would like to go back to my presentation. And as Anouk already said, I will present on the effects of exercise in patients with metastatic disease. And the focus of my presentation will be on the preferable effect study. And you might have already have heard a presentation on this study, but today I have some more time, so I will include more results. As you all are aware, in the last years, there were a couple of exercise oncology guidelines published. These were either international or national guidelines. And one of these guidelines was published by the American Society of Clinical Oncology. And this guideline focused on the effects of exercise during cancer treatment. And what we learned from the extensive literature review was that there is now enough evidence to conclude that exercise during adjuvant treatment leads to improvements in fitness, strength, fatigue, and other patient-reported outcomes. And that brought us to the recommendation that oncology providers should recommend regular aerobic and resistance exercise during active treatment with curative intent. However, we also discovered some research gaps, and one of the gaps was that there was a lack of studies in the metastatic setting. So we could not issue any recommendations for the metastatic setting at that moment. So I also now looked in the literature searching for more studies because the ASCO guideline has already been published a couple of years ago. But still, when I looked, there was one systematic review published in 2023. And in that review, they reported that there were 22 RCTs with patients included in the metastatic setting. The sample size ranged from 12 to 269, but this last large study was a study that included also about half of their sample was patients in the curative setting. Most studies in the metastatic setting so far have been done in patients with lung cancer, followed by breast cancer and prostate cancer, or a mixed population. Here you can see an overview of these studies. So the duration of the exercise intervention was ranged from 2 weeks to 6 months. Some included aerobic exercises, some resistance, and the majority had a mixed exercise program. If we look at recruitment rate, I think a recruitment rate of 56% is quite good. Retention was also high, 80%. Adherence was 70%, which is somewhat lower, slightly lower than in the adjuvant setting. In this review, they also investigated adverse events in the advanced setting, and the conclusion was that in these studies that have been performed so far, only 4 exercise-related adverse events have been reported, and these were mild adverse events. And there was no increased risk of grade 2 to 4 adverse events in the exercise group compared to the control group. In this slide, you can see the summary of the results of these studies. And from this summary, and there needs to be some caution because some studies were a mix between adjuvantly treated patients and palliatively treated patients. But still, it seems that positive effects are also present in the advanced setting. So they found that quality of life, fatigue, and aerobic fitness, strength was better in the exercise group, and also there was an indication of a positive effect on pain. But still, the conclusion was that there is a suggestion of positive exercise effects, but the populations included in these trials were very heterogeneous. Time since diagnosis ranged from 0.2 months to 9.8 years, and also most of the trials had a rather small sample size. So if you now focus on trials that have been done in the metastatic breast cancer setting, so focusing on one tumor type, there was one systematic review published in December last year, and there they found 3 studies. And as you can see here, these three studies, one was rather large with 100 patients, but the other 2 were small studies. Treatments were mixed, and also the duration of the exercise interventions were heterogeneous. And in this systematic review, the authors concluded that they could not do a meta-analysis due to the limited sample size. From looking at the 3 studies, they concluded that there seemed no effect on quality of life, and there was a suggestive effect on fatigue, but uncertainty was high. So in that systematic review, the preferable effect study was not yet included, and so the inclusion of that was that there's still insufficient evidence. And now I will move to the preferable effect study, and that study was published last year and thus not included in that systematic review. In this preferable effect study, we studied the effects of exercise on fatigue, fitness, and quality of life in patients with metastatic breast cancer. And the aim of this trial was to investigate the effects of a supervised and individualized exercise program. And we included patients from 8 clinical centers in 5 European countries and in Australia. Patients who were adults had a diagnosis of breast cancer with the stage 4 and a life expectancy that was estimated to be 6 months or longer were eligible for our trial. Exclusion criteria were contraindications for exercise, unstable bone metastases, and patients who were too physically active, could not attend. Here you can see the design of our study. So patients came to the research center for extensive baseline measurements. We did questionnaires, blood sampling, and fitness testing. And after informed consent and baseline measurements, we randomized the patients to either a 9-month intervention group or the control group. And the control group received a general physical activity advice and a Fitbit. All measurements were repeated at 3, 6, and 9 months, and at 6 months we assessed our primary endpoint. If we look into the exercise program, this was a program which was offered twice per week for 1 hour each session in the first 6 months, and in the last 3 months we replaced one of the supervised sessions with an unsupervised session. The exercise intervention consisted of aerobic, resistance, and balance training. And here you can see that in more detail. So the session started with a warm-up, and then balance training, strength followed by strength training, and endurance training. And we used for all this a periodization. So here, for example, for the endurance training, you can see that in the first 3 weeks, there was a moderate intensity, continuous training offered to the patients. And then we started with high intensity interval training, and we changed the intervals over the time. And we did the same periodization for resistance exercises. And if you are interested in this program in more detail, you can go to our website and you can download the exercise program and all documentation material you need to repeat the intervention. We also adapted the exercise program based on locations of metastasis. So if that was necessary, patients were given certain exercises that they could do better if there were, for example, metastasis in the pelvis. Also, this is explained in the documentation on our website. If you are more interested in what you can do with patients who have bone metastasis, you can always visit this website. On this website, all the current evidence is summarized, and you can see webinars, you can find patient handouts, or also a referral tool so that you can guide your patients based on metastases. This website is currently available in 6 languages, and I would like to acknowledge Kristen Campbell, who is the initiator of this website. So going back to the methods of preferable effect, here you can see our endpoints. We had 2 primary endpoints. We measured physical fatigue and quality of life with the ERTC questionnaires. And before the trial, we defined that our trial would be successful if either or both of these endpoints would be statistically significantly different between the intervention and the control group. We also measured several secondary endpoints, and some of them I will present to you today as well. Here you can see the baseline characteristics of our participants. We randomized 178 patients in the intervention group and 179 in the control group. The mean age of our patients was 55 years. In both groups, we had 1 man, and the majority of patients had endocrine treatment at start of the study. Most of the patients had recurrent disease, were treated in first and second line, and had bone metastases. And the baseline characteristics were well balanced between the groups. So if we look at attendance and adherence, we can see that the patients participated in a median of 77% of all sessions. At 6 months, 18% of our patients discontinued with the study, and that was in 44% of the cases due to death. And other reasons for discontinuations were, for example, progression of disease, and there was no reason that patients disliked the intervention. In our sample size calculation, we had estimated a discontinuation rate of 20% after 6 months, so this 18% was included in our sample size calculation. Here you can see the results for compliance to the exercise intervention, and you can see that for all parts of the exercise intervention, compliance was 70% or higher. And in this study, we had 2 serious exercise-related adverse events. These 2 were fractures, and none of these fractures were related to the disease or to bone metastases. Now I would like to start with the results for physical activity and fitness. If we, of course, looked into the physical activity behavior, because that tells us something on, of course, how active the intervention group was, but also on whether the control group was also active or not. So whether there was contamination in the control group or not. Let's start with the step counts, which we retrieved from the Fitbit. You can see this is the baseline step count, and as you can see, the control group had a somewhat a higher step count as compared to the intervention group. And during follow-up, you can see that the step count was higher in the intervention group as compared to the control group. Here you can see results for resistance training, which was assessed with a questionnaire. And first I would like to explain to you the zeros you can see here. And this means that at baseline, in both groups, the median report of doing resistance exercise was 0. So that means that most of the patients did not do any resistance training. If you then look at 3, 6, and 9 months, you can see that the intervention group reported what they were asked to do. So they reported 60 to 30 minutes of resistance training per week. And in the control group, this was still 0. And if we then look into the moderate and vigorous intensities that were reported, you can see that both groups at baseline did not report to perform moderate or vigorous intensity aerobic exercises. And then you can see that, especially for vigorous intensity exercise, this was significantly higher in the exercise intervention group and 0 for the control group. So from this, we can conclude that the intervention group increased their physical activity levels and the control group did not, and so we think that contamination was low in this study. So here you can see an overview of the fitness outcomes we measured in preferable effect. So we did endurance testing, balance testing, muscle strength testing, and also some functional testing. And we also did a STIP ramp test as the overall assessment of exercise capacity. And I start with results for the steep ramp test. And here you can see that the exercise capacity was higher in the intervention group as compared to the control group at 3 and 6 months. And so the intervention really had effects on the fitness of the patients during their treatment for metastatic breast cancer. Also for the endurance test, we found significant beneficial effects of the intervention. Here you can see that also balance was improved in the intervention group or higher in the intervention group as compared to the control group at 3 and 6 months. And for the 5-time sit-to-stand test, we found that this was significantly different after 6 months. For muscle strength, we looked into the leg press, so the upper leg muscle strength, and we found that this was higher in the exercise intervention group as the control group. Only for hand grip strength, we did not find a significant difference. So taking this together, we can conclude that patients improved their physical fitness and also their functioning in the intervention group. And now I will report on our patient-reported outcomes and start with our primary outcomes, which was quality of life and also fatigue. And what you can see here is that quality of life was higher in the exercise intervention group as compared to the control group at 3, 6, and 9 months. And also for fatigue, this is the lower line, we found that the exercise intervention had beneficial effects on fatigue at 6 and at 9 months. So from that, we can conclude that the trial was successful. If we now look into more details in quality of life, because the primary outcome was a summary scale of quality of life, then here you can see that patients also report improved physical functioning, higher role functioning, and higher social functioning during the intervention period as compared to the control group. Only for emotional fatigue and emotional functioning, we did not find differences between the two groups. So here we think that an additional intervention should be added to exercise if this is really a concern for the patients or for a specific patient. We were also interested in symptoms because we saw that symptoms like pain and dyspnea were quite high in our participants. So almost 60% of our participants reported to have elevated symptoms of pain and dyspnea at baseline. And what we also did in Preferable, we performed a survey. We asked 420 patients with metastatic breast cancer in Europe about their facilities and barriers for starting or performing exercise during their treatment. And one concern that was mentioned was that they had concerns that symptoms like pain and fatigue would worsen while exercising. And I already showed you that fatigue decreased during exercise, so that should not be a concern. And also, if you look at pain and dyspnea, we found that pain decreased and was lower during the whole intervention period in the exercise group compared to control. And for dyspnea, we found a significant difference at 6 months. So also here, we could tell patients that they should not be concerned that symptoms worsen, but of course symptoms should always be monitored, and the exercise program needs to be adapted if symptoms would worsen. Another interesting outcome is sexual health. When we did our literature review for the ACSM guideline, we concluded that at that moment there was not enough evidence to conclude on sexual health. So, but we still classified this as an upcoming outcome where we should do more research on. And in Preferable, we looked into sexual health. What you can see here is that 60% of our participants reported to not be sexually active. Of those who were active, almost half reported to have no or little enjoyment. And when we focused on the patients under endocrine treatment, we saw that the symptoms or the complaints they report were mostly that they had complaints of a dry vagina and also a dry vagina during sexual activity. So the question now is, we do have a sample who have complaints. Could exercise help here or not? And here we show you the results of the exercise intervention. And what we could conclude is that there were positive effects of exercise on sexual functioning, and also in patients under treatment, under endocrine treatment, we saw beneficial effects on the endocrine sexual symptoms. And furthermore, we also saw an indication that exercise might affect sexual enjoyment, which was not statistically significant, but if you look at the effect size, this one after 9 months was comparable to the other effect sizes. So these were the results of our studies. And what we also did, we asked patients on did you like the exercise intervention? And results on that were presented at the Moving Beyond conference in Lisbon this month. And here I would like to summarize the conclusions of our satisfaction questionnaire. And the first thing was that during our perspective study, that was the survey we sent to the 420 patients in Europe, we found that patients said that they would prefer walking and lower intensity exercises. But of course, that from in any case, the studies in the adjuvant setting, we know that you can get larger effects of exercise if intensities are moderate to high. So we would, of course, like to have patients in the metastatic setting to train them with the same high intensities. So we were happy that from Preferable effect, then we could conclude that the satisfaction questionnaire showed that patients said that the intervention, which was moderate to high, had a moderate to high intensity, was enjoyable and acceptable. And we get high rates for the supervision, the tailoring of the program to individual needs, and also patients rated the social connectedness high. So what I would like to give you now is a perspective of one of our participants. This is Ineke. She is from the Netherlands, and she presented during our final conferences her view on the participation of the intervention. And I will share the video from that conference now with you. And now happens what I already thought that should happen, that you cannot hear it. I think, let me...
Now we are going to listen to a real life story. So Ineke, the floor is yours. Well, nice to meet you all. This is me on the outside. My name is Ineke. I'm from the Netherlands. I've been participating in the effect study, and will give you some an insight in my experience. Right now, I'm 57 years old. I have a university degree in sociology, and I work for 27 years now as a freelancer, coaching and of managers and teams. At the time they found out that I had metastatic breast cancer, I was 53 years old, and my children, a girl 15 and a boy of 18 years old. Too young. At this stage, I cycled about 20 kilometers a day. This is a way of daily transport to give you an insight in my physical training. In 2019, I visited my GP with the complaint of higher back pain. She diagnosed me with a burnout. Although I had my doubts, I went along with her diagnosis. But knowing what I know now, it was not surprising that I had increasing complaints, pain, and fatigue over time. After 11 months, I was hardly able to sit up anymore or walk around. I suffered from terrible nerve pain, and 1 month later, I received an MRI. Everyone was shocked when they saw that 5 vertebrae were decompressed, impending spinal cord compression, an unstable spine with a risk of high spinal cord injury. The diagnosis of hormone-sensitive breast cancer with bone metastasis. You have a terrible profession. No, apologies. Yeah. Emergency surgery followed by the spinal trauma team of the University Medical Center in Utrecht. They really saved my life. After that, I was treated with local radiotherapy, and that was all. The good news, that's me, just after the surgery, after a few days. The good news was that I didn't get paralyzed from my head down and that I was still alive. The less good news is that I must hold up my head. The fence that has been placed in my back is placed like a curve, like this. So my forced natural posture is something like this. And of course, I don't want to live like this, so I always have to straighten up. I'm limited in turning my head, so still like this and like this. And I still have a leftover of my nerve pain, which is not very nice either. I will give you a very fast, quick impression of my insides. And you can see it, it is with and without meat and with and without bones. So you, in the end, you only see the fence and how it is. Yeah. Yeah. Okay, quite impressive. Yeah. After surgery and radiotherapy, my recovery started. I left the hospital with a walker and started my revalidation at the UC Revalidation Clinic. It took me about 4 months before I could replace my walker by a walking stick. It took me about a year before the nerve pain was bearable and I could stop bit by bit with stop with the pain medication. I remember that the spine surgeon told me that within the first 6 months, my body would recover the fastest. After 12 months, when I saw him again, he told me that most of the improvements had taken place by now. I left the hospital after this consultation thinking, oh my God, what am I going to do if this is it? The muscles in my upper back felt like concrete. I was tired of holding up my head. And I still had nerve pain in my arm and hands. I felt very sad. When I told my new GP, she stepped back, looked at me, mused, and then spoke the following words. Scientifically, he is probably right. But looking at you, I don't think that your development has come to an end yet. With this in mind, I was very lucky to become a participant in the effect study. But I've told you now about my pain and my struggle. But before I tell you more about my experience with the effect study, I want to ask you a few questions. You asked me so many, so I think I can ask you. I want you to go back to a moment in your own life when you experienced pain. And what I would like, if you responded to this pain by painkillers, perhaps you can raise your hands. Next question. If you responded with visiting a GP or another healthcare professional, please raise your hands and look around so you have an impression. If your response was crying and or swearing, please raise your hand. And if your response was curling up in bed or the couch, please raise your hand again. Yeah. And finally, if your response was going to the gym, please raise your hands. Although I have become a believer that exercising really helps to gain back your life, exercising is not the logical step. Keeping this in mind, I wasn't sure that the fact that I was accepted in the effect study was good or bad news. I was worried about my balance and experiencing pain in my upper back and arm. Plus, I must admit, I wasn't a fan of sports and definitely not the gym. Okay, this is my physical therapist, Lisanne, and she's amazing. And with becoming friends, I mean, I had to trust her. She had to become attuned to me, but also talking about daily life and the good things that happens really, really helps. Lisanne asked me to step on the balance ball. My answer was a very decisive no. In the beginning, she had to negotiate about every new exercise with me. I was afraid to fall, and the pain that might occur. However, by using the start low and go slow principle, I realized I could do much more than I thought. Since I couldn't rely on my back for balance anymore, she also paid extra attention to core and balance training. Cycling on a stationary bike was not easy for me. The handlebar didn't fit my new anatomy. Another patient in the gym, who was a welder, made an adapted handlebar for me. This allowed me to follow the effect protocol. I realized I could do more than I thought. I built up muscle strength and balance. I arrived with a cane and left without one. In daily life, I was able to do more, like getting on and off a bus and picking things up from the floor. It's amazing how much you drop every day. To my own surprise, I got more self-confidence and I was able to relax within the boundaries of the fence in my back. To prove that a lot has happened since I started, I want to complete with a small video. This is me outside the gym. It's actually also the structure when you're so ill that you just have to go there twice a week and you meet all those people twice a week. And well, of course, the rest you've seen. Thank you very much.
So I think that this patient perspective really shows us what all these benefits we report from in our trials mean for the individual patients. And Ineke still goes to the gym twice per week, and she still had even more positive effects than after the 9 months intervention. So I think that also learns us that improvements can continue beyond a certain intervention, especially in patients under treatment. And we were very happy that Ineke was and is still willing to share this story with us, because she is also giving other presentations now to tell her story. And of course, one of our aims is that we want to implement our results. And one prerequisite to implement results and get reimbursement for exercise is also showing that the intervention is cost effective. And that is what I now want to present to you in the last part of my presentation, because alongside with the preferable effect study, we also performed a cost effectiveness analysis. And I will give you some general details on how to perform such an analysis and then show our results. So the aim of a health economic evaluation is to investigate whether the 9 months supervised exercise program was cost effective compared to the control group. So when you perform a health economic evaluation, you start with looking at costs and benefits. So what we have in both the exercise and the control group, we look into costs of the intervention. For the exercise group, that was the 9 months exercise intervention and the activity tracker. The control group received usual medical care and also an activity tracker. Next, you look into consequences, and then we collected direct healthcare use, indirect healthcare use, indirect non-healthcare use, and also the quality of life of the patients and the duration of life. And if you have all this information, you could calculate the total costs and the total effects in both groups, and then subtract or divide these, and you can find your cost effectiveness analysis. First, we looked into quality of life, and this was measured with the EQ5D, and then we calculated from this the QALYs. And what you can see is that in the QALYs, or the quality of life, was higher in the intervention group as compared to the control group during the whole intervention. Next, we calculated the costs of the exercise intervention, and we did this for 2 scenarios. First, we looked into how much exercise costs if a patient receives one-on-one supervision, and then we looked into the scenario of performing the exercise intervention in a group, and we used the 1-on-4 supervision scenario. For both scenarios, we calculated the costs for the intervention, and we found that the costs was about 1,700 euros if it was one-on-one supervision, and 684 euros for 1-on-4 supervision. And here we show the average intervention costs per participants across all preferable effect centers. Here in this table, I will show you the medical costs, so cost regarding direct and indirect non-healthcare use and healthcare use. First, we looked into costs for primary care, and here you can see that these costs were comparable in the two groups. For hospital care, we found that the costs were lower in the intervention group as compared to the control groups, and that was mainly due to less visits to the emergency department. Also, costs for home care were lower in the intervention group, and informal care was also lower in the intervention group. And lastly, we also looked on productivity loss at work, and we found that there also the costs were lower, so less loss in the intervention group as compared to the control group. And this was mainly due to less short-term sick leave in the intervention group. So if we take this together, we can conclude that the total costs in the was lower as compared to the control group. We found that quality of life was higher in the intervention group, and now the next step is to look whether the costs we add with the intervention are outweighed by the costs, this cost reduction, and also the benefit in quality of life. And this is then displayed in an incremental cost effectiveness ratio, which you can see here, or the cost effectiveness plane then. And what you can see here, that you can put your results in this plane, and what you wish is that, of course, the results would be in this quadrant, showing that the intervention is less expensive and more effective. What we also have is in countries a threshold value of willingness to pay. So how much euros are we willing to pay for a quali? And in the Netherlands, this is, for example, 20,000 euros that we are willing to pay for a gain of one quali. And so what we want is that the results are below this threshold value of willingness to pay. Here you can see the results for effect. And first we show you the results for the one-on-one supervision. And what you can see here is that most dots are below this threshold of willingness to pay of 20,000 euros. And if we take this threshold, then the probability of cost effectiveness is 65%, which is an acceptable probability in cost effectiveness analysis. For the 1-on-4 supervision, we found that even that the probability of cost effectiveness was 91%. So very high. And if you take, for example, a threshold of 80,000 euro, the probability would be even higher. So from this, we could conclude that the intervention is cost effective. And this brings me to my overall conclusion, and that is that we found that a supervised resistance and aerobic exercise intervention resulted in beneficial effects on fatigue, quality of life, fitness, sexual health, and other clinically relevant outcomes in patients with metastatic breast cancer. We can conclude that exercise for patients with metastatic breast cancer decreases medical costs. Both individual and group supervision are likely to be cost effective, and group supervision is even more cost effective. And we believe that supervised exercise should be reimbursed for patients with metastatic breast cancer. And we recommend supervised exercise as part of supportive care regimens during metastatic breast cancer treatment. So for that, I would like to say thank you for your attention. And as a last slide, I would like to acknowledge my team, because this preferable effect study was a common effort of many great researchers in Europe and Australia, and I would like to acknowledge all of them, also the physiotherapists, the nurses, and healthcare providers who referred patients to us, and our funders, the European Union and the Australian government. And lastly, this is again the announcement of the inaugural conference of ISEO in Heidelberg next year. So I hope to see you there in person. If you have any questions, please feel free to ask them now.
Yes, thank you very much, Anna, for your wonderful presentation. I would like to invite everyone to or unmute yourself and ask your question directly directly, and otherwise you can add it to the chat. In the meanwhile, I will start with some questions. I was wondering, so this study focused on patients with metastatic breast cancer. And do you think that a similar exercise intervention could be beneficial for patients with other types of metastatic disease? And what should be taken into account to adapt the exercise program accordingly to these cancers?
Yes. So I think that given that our exercise intervention is individualized, this could be also given to patients with another metastatic diagnosis. But I'm not sure whether we can generalize our results to another group, because patients with metastatic breast cancer do have a quite good prognosis as compared to other patient groups. So I think that we definitely need more research. As you also know, we have, for example, now perform a study including patients with esophageal cancer, and there we experienced that, life expectancy is shorter, the risk of early progression is higher. So there we need also to adapt the program on the way more often as compared to this group. So I think we definitely need to wait for more results to draw a conclusion for a general conclusion for the advanced setting.
Yes, thank you. Then another question about the implementation of the exercise program into clinical practice, because given these positive outcomes for patients with metastatic breast cancer, of course, you would like to implement it in clinical practice. What are potential barriers for implementing this? And mainly, for example, in more research limited settings like Poland, which was also included in this study.
Yeah, I think that implementing results is a different area. So it's not very easy. And especially, for example, in countries like Poland. So Poland was one of our, we had a center in Poland, and we saw that there indeed also the offer is limited. So there I think we really need to do implementation research or a guided implementation in the countries, and that should be country specific. So I think we are still not there. So, for example, for the Netherlands, I think that we need to create more awareness still, but I also know that patients are referred, so that's the good news. And reimbursement is at the end, I think, crucial.
Yes, totally agree. Then, well, it's a multinational. Oh, yeah, Justin.
Hi, Justin.
I'm on the road, so I just show you some flowers here in Korea.
Wow.
I will
But anyway,
now I can see you.
okay,
So you are outside.
Oh, yeah, I'm outside. I'm on the road. Excellent talk. In your exercise intervention, you start with the balance exercise. And I mean, and a balance exercise is included in the exercise guideline. But is there any specific reason that you start with the balance exercise?
Yes, we started with it also a bit like as a warming up. And also we wanted to do the balance exercises when patients not already are fatigued by resistance or endurance exercises. So that was the main reason why we started with the balance exercises at the beginning.
That's actually, nowadays we see the balance exercise is actually the exercise for the brain.
Mm-hmm.
Actually, it stimulates the salience network where we perceive pains and even immune system. So I think it was brilliant that you start with the balance exercise for these patients.
Thank you. And we were also lucky to see effects on balance. So we did not measure effects, of course, in the brain and things like that, but we saw that they improved their balance. So that was good.
Yeah, that was very unique. Thank you.
Any other questions from the audience? And I would like to ask one final question, maybe on, because it's a multinational trial and many sites were involved. How did you make sure that the exercise program and the measurements were standardized across the different sites?
Good question, Anouk, and I think you also know a lot about that. I think that what we did, when we prepared the study, we did a training so that we trained all the persons who did the measurements, that they did all the tests together. And of course, we had that detailed protocol. I think that there are always some differences in the intervention. Not that the content was the same, but the setting was, in some countries, it was done in a gym. In the Netherlands, we had physiotherapists supervising the intervention. Somewhere in the same center all the time, somewhere. So, for example, in the Netherlands, we had physiotherapists for another physiotherapist for every training. So I think there were some differences, but I also think that's not a problem because, yeah, if you do a study that you want to implement in the care in that countries, it's good that it's done how they will also do that afterwards. But in general, we ensured that the protocol was standardized, and also there was a detailed documentation of what has been done during every session, and we reviewed that. And by that, you can also, during the performance of the trial, check whether you see differences between sites. And we also had regular meetings where we discussed all the things that come up. And by that, if you talk about this, you can also discover if there might be differences, and then you can adapt that. So I think it's important to have a close monitoring, close contact between sites. And yeah, as you know, we had a weekly meeting with all people who were hands-on involved in the study. And I think that was, I would say, one of the success factors.
Yes, thank you very much. Yeah, then it's almost 10 o'clock, at least here in the Netherlands. So I would like to wrap up this webinar. I want to thank Anne for her excellent presentation and the great discussion. And as a reminder, I would like to mention that today's webinar has been recorded and it will be posted on the ISEO website in the next few days. And then we have our next ISEO webinar series planned on the May 23rd. Then Sandy Hayes will present from the Virtual Cancer Research Centre from Queensland, Australia. And you can visit the ISEO website for more information on the entire webinar series. So thank you all again for joining today, and we are looking forward to see you the next webinar session. Have a great day.
Bye-bye.
Bye-bye.
Thank you. Bye bye.